Hello everyone, I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Today we will be studying about Lichen Planus. Okay, before that, just look at this figure. What is Lichen Planus? It is purple, flat, and top bumps that you are able to see in your hands. Like if this is my hand, then the bumps will be over here. Red, tiny bumps will be there. Okay. So lichen planus is basically a chronic inflammatory autoimmune mucocutaneous disorder. It is a chronic and inflammatory disorders characterized by pruritic, villaceous, polygonal, flat-topped papules and plaques. So papules and plaques will be there. Like if this is my hand and over here I am having some red kind of thing and they are having plaque as well. So it is mainly lichen planus. Okay. It affects the skin, mucous membrane, the nails and your hairs. Okay. If I talk about the epidemiology, so it is most common in adults who are at the age of 30 to 60 years. In 30 to 60 years, it is most commonly affected. If I talk about the gender dominance, then it is a female predominant disease. Okay, females are more likely to develop this kind of disease as compared to the male. The prevalence is around 0.5% to 1%, and geographically it is worldwide distributed. If I talk about the etiological risk factors, then first one is the autoimmune reaction. There is cytotoxic CD8 T-cells that are there. They attack the cytotoxic CD8. They attack the basal keratinocytes. After that, what happens is there is basal degradation. There is basal degradation. Then you have the genetic predisposition, like you have the HLA association of 𝗲𝗵𝗵𝗵 and 𝗲𝗵𝗵𝗵21. What are the triggers you have? The drugs will be anti-malarial drugs that we give for the treatment of malaria. Beta blockers can trigger it, ACE inhibitors, NSAIDs and thiazides. Then you have the hepatitis C virus, which is also a trigger for this kind of disease. Then you have the dental materials like the amalgams that are there. Then stress, like if the person is taking a lot of psychological stress, then there are chances that the person will develop this kind of disease. Okay, there are oral infections like HPV, but the oral infections are rare. So these are mainly the etiology and the risk factors that are there and that are involved. Okay, next is about the pathogenesis. So in the pathogenesis, what happens is there is antigen presentation. There is basal keratinocytes are present antigen to the CD8 T-cells. Okay, then there is T-cell activation. After the recognition, there is T-cell activation, and after the T-cell activation, there is cytokine release, right? There is cytokine release and it has TNF-alpha, interferon gamma, and interleukin 2, sorry. Then you have the interface dermatitis. It is basically the degeneration of the basal layer. What are the clinical features? For the clinical features, you have the shape is polygonal and surface it is flat top. Papules are there. Distribution can be found in your wrist, ankles, lower back, lumbar regions and flexure surfaces. What are the other features? You have something called as the Koebner Phenomenon that I have already told you in another videos, that if like here I am having the lesion, then here only there will be a small tiny thing that I will be able to see, a small tiny bump that I will be able to see, and that is called as your Koebner Phenomenon. Second thing that you have is the Wickham Striae. They are fine white reticular lines on the lesion. See this beautiful figure in your mouth. You are having this white kind of line. These are nothing but your Wickham Striae. Okay. In the nail changes, you are able to appreciate the longitudinal ridges and pterygium formation. What is pterygium formation? I hope that you have read in your ophthalmology what is pterygium. So pterygium is nothing but triangular. It is like a formation of a triangular formation in your eyes. Okay, you will read more about the pterygium formation in your ophthalmology classes. Okay. The common sites that are involved are your buccal mucosa, tongue, gingiva, and the lips. The forms are, you have the reticular form, like that it will be lacy and there will be white Wickham Striae will be there. In the erosive phase, it is painful. You have ulcerative and higher malignant potential. Symptoms will be, there will be burning sensation, pain, sensitivity to spicy food. The patient will not be able to eat the spicy food. Okay, and that is very, very evident, and we should also not allow the patient to eat the spicy food, because if the patient is having the Wickham Striae in his or her mouth, then how will he be able to take the spicy food, right? There will be intolerance to the spicy food. Even if the person takes the spicy food, there will be a lot and lot of response that the person's body will show. Okay, in men, the part that is involved in the lichen planus is the glans planus. In the females, it is the vulvar part. Then the other sides are in scalp. It is called as the lichen planopilaris, that is scarring alopecia. You know what is alopecia? Alopecia is nothing but like alopecia is nothing but the hair loss. Okay, alopecia is nothing but the hair loss. So in alopecia also you have the types of alopecia. Okay, see, since this is not your dermatology class, but there is a female pattern of alopecia and there is a male pattern of alopecia. See, females apply sindoors, right? In our Indian tradition, they apply sindoor. So sindoor has a lot and lot of chemicals in it. So female mainly go bald. Mainly the hair, there is less hair in the middle partition of the females. Whereas in males, there is the side partition in which they are having a less number of hair. Okay, so hair loss will be from the side partition. In the nails, you will be able to see that there is thinning of nails, there will be longitudinal ridges and nail loss. There will be esophagus and conjunctivitis. Conjunctivitis is also involved, but it is involved in rarely. Then you have the variants. First one is the hypertrophic lichen planus. It is thick and hyperkeratotic plaques are there that are found on the shin. Okay. In the atrophic lichen planus, you have the thin skin and post-inflammatory. We are able to appreciate that once the process of inflammation has occurred, then we are able to appreciate the atrophic lichen planus. And the bullous one, see, B for B. Bullous is blisters. So B for B. Okay, bullous is for blisters. Then you have the lichen planopilaris, that is scarring alopecia of your scalp. Then you have the linear lichen planus that follows the Blaschko's line. Okay, you have something called as the Blaschko's lines that you will read in your anatomy. And if you are not aware about the Blaschko's line, I would suggest you to go to your anatomy lecture, the journal anatomy part, and just see there. Okay. Next thing, what are the investigations you will order? First one is clinical diagnosis that will be based on the morphological distribution and obviously on the Wickham Striae if it is present or it is not present. Histopathology is a gold standard, okay, that we do. In hyperkeratosis, there will be hypergranulosis, sawtooth pattern in the rete ridges. Okay, you have this. This is like a sawtooth pattern that you will be able to appreciate in the rete ridges, right? Then there is band-like lymphocytic infiltrates at dermo-epidermal junction. Dermo-epidermal junction, right? Like this is the dermis. This is the epidermis. So this is basically what? This is nothing but your dermo-epidermal junction, right? So there will be a band of lymphocytic infiltrates that will be present over here. The blood test that you will order only if systemic associations are there. What is the differential diagnosis? First one is psoriasis. In psoriasis, you will be having the silver scales, not polygonal. In eczema, there will be acute lesions, vesicles will be there. In the lichenoid drug eruption, there will be a history of drug. And in the leukoplakia, that is oral. See, leukoplakia, in leukoplakia also you are having white kind of thing, but they are mainly present in your tongue. So you have the erythroplakia. If the plaque color is red, it is called as erythroplakia. And second you have is the leukoplakia if the plaque color is white. What are the complications that can be there? There can be oral lichen planus. There will be oral squamous cell carcinoma. Scarring alopecia will be there. Nail loss will be there, and chronic pruritus leading to the lichenification. What is the treatment? For treatment, you have to take the general measures, avoid the traumas. That is called as the Koebner's phenomenon, right? Because Koebner's phenomena were occurring at the place of trauma only, so avoid that. Stress management should be there, and discontinue triggering drugs. There should be topical therapy that you should give to the patient, like the corticosteroids. Then there should be potent steroid ointments. For oral lichen planus, you have to give a triaminoclone acetone paste. Okay. What is the systemic therapy? For the systemic therapy, you will go for the corticosteroids, retinoids, and immunosuppressants. Then you will go for the phototherapy and then for the systemic treatment. What is the prognosis? So, in the prognosis, the cutaneous lichen planus often resolves within the 1 to 2 years. The cutaneous lichen planus usually resolves at 1 to 2 years of gap. Oral lichen planus is chronic and may persist for years. Okay, it is malignant and transformation risk is higher. Next thing, what are the key points on mnemonic? You have to remember the 6 P's. What are the 6 P's? It is pruritic, it is purple, it is polygonal, then planar, plaque is there, and papules. So these are basically the things that you need to remember. And the most important, Wickham Striae, how can you forget that? So it is a white lacy lines on the papules, especially on the oral mucosa that is there. Then you have Koebner's phenomena. In Koebner's phenomena, it is the lesion at the site of the trauma. I have told you multiple of the times. I hope by now you are able to remember what is Koebner's phenomena. Let's solve an MCQ. Which of the most characteristic clinical feature of lichen planus? Is it the Civatte scale? Civatte scale is for psoriasis, right? Is it the honey color crust? No. Is it the targeted lesions? No. So the option to this is Wickham Striae. And Wickham Striae is the most characteristic. It is the most characteristic clinical features of lichen planus. So just remember the 6 P's that you have in the lichen planus, and you are just sorted with this chapter. If you are having any sort of doubt, please feel free to reach me. Please feel free to DM me. Thank you so much.